All right, I am a believer in starting on time, so I'm going to go ahead and do that. Greetings, everyone. My name is Renad Betis. I'm the chair of the Department of Medical Social Sciences. Welcome to the IFAM seminar series. For our online viewers, please be aware that we will not be monitoring chat during the seminar. If you have questions for the speaker, please use the Q&A function, and we will do our best to answer them during the Q&A section if time permits. So it is my great pleasure to introduce Dr. Chris Rini. Dr. Rini is a professor in our Department of Medical Social Sciences. She's also program leader of Cancer Control and Survivorship in the Cancer Center, as well as director of research translation for the Cancer Center's Cancer Survivorship Institute. She's also director of the Social Science and Health track of the Health Sciences Integrated PhD program, thus contributing to our educational mission. So thank you, Dr. Rini. I believe that Dr. Rini's work very well exemplifies our transdisciplinary approach in medical social sciences. It maps onto the two divisions of determinants of health and intervention science. She's a social and health psychologist who conducts research to understand factors that influence patients' behavioral and psychosocial responses to health-related challenges. One of her longstanding interests involve interpersonal processes through which partners, family members, and peers can influence patients' health decisions, behaviors, and outcomes. She's also committed to translating research findings into behavioral and psychosocial interventions, including those delivered using technology. Thank you, Dr. Rini.
Thank you so much for that introduction and for the invitation to speak today. I'm really excited to share this work with you. This was actually, this is work that's been going on for 15 years. It was my first R01. Like a lot of projects, it sometimes has gone on the back burner, sometimes comes to the fore. It's been really active for the last 5 to 7 years or so as NIH has devoted funds to looking at non-pharmacologic approaches to reducing opioid use for chronic pain. And this is an intervention that fell within their interests, and it's been tested in several HEAL trials that are wrapping up now. I'll tell you a little bit about those. But first, why do we care about chronic pain? You may know somebody who has it, you may have it yourself, but it's a very serious public health problem in this country. About almost 25% of adults in the US have chronic pain, which is typically defined as pain on most or all days of the week during the last 3 months. And nearly 9% have high impact chronic pain, which is chronic pain that restricts life and work activities. That's one of the most common reasons people seek medical care and puts a lot of burden on our healthcare system in addition to our society and individual well-being. So our interest in this work has been on pain coping skills training. So chronic pain is a biopsychosocial condition. It's known to be affected not only by the biological systems within the body, physical damage, inflammation, and such, but also psychological and social components, and cognitive behavioral therapies really address those psychological components. So behaviors, thoughts, and emotions that are known to contribute to the experience and the disability caused by chronic pain. So pain coping skills training is a flavor of cognitive behavioral therapy. It's informed by it. It was developed by Dr. Frank Keefe, who is the major collaborator on this work. He's at Duke University. We've been working together since the beginning. And there are two important components to pain coping skills training. So one is education. Of course, we tell people why they're learning these skills, what it is that these kinds of skills they're learning will contribute to helping them manage their pain. That includes a therapeutic rationale, and I'll tell you a little bit more about that, but it's a simplified version of gate control theory and the neuromatrix theory of pain. And it also involves skill training, and our work takes a particular approach to skills training that I'll tell you more about. So what are these skills? progressive muscle relaxation, brief relaxation exercises that people can use while they're walking, standing in line, sitting at a desk. Attention diversion techniques such as pleasant imagery or pleasant activity scheduling. Managing activities, imagine, doing like yard work or getting ready for a holiday or something like that, where you're doing a lot of physical activity and exacerbating pain so that you experience a lot of downtime afterwards versus taking breaks and managing it so you don't overdo it. Cognitive restructuring, so catastrophizing thoughts like this is never going to get better, I'm never going to have a normal life again. Learning to recognize them and counter them with more adaptive coping thoughts. And problem solving. How do you learn all these skills and decide when to use them or what combination to use them? And how do you maintain new behaviors over time? Because that's what you need people to do if they're going to benefit from this kind of intervention. So there's a lot of evidence behind this approach to pain management across multiple pain conditions. Most recently, I think there's been a little bit more emphasis on cancer pain and neuropathic pain, for instance, caused by some cancer treatments, but of course, other things as well. It has been the case in many of the large studies that patients who have cancer or pain due to cancer are not included in research. And so it's really good to see some focus on cancer pain in recent years. And I'm going to tell you a little bit more about that. But it's across multiple pain conditions. And when we're thinking about medical pain treatments, it's often very important to think about this type of pain or the source of the pain and match that to the medical treatment being delivered, of course. With pain coping skills training, it's in my mind, okay, social health psychologist, I'm not an MD, I'm not a clinical psychologist. I have collaborators for that expertise. But from what I've seen and heard from patients and heard from physicians is that pain is pain, that this is a really broad set of skills that people can use for a lot of different things. And that's certainly showing up in the research. It's also, because the research supports this approach, it's cognitive behavioral approaches or pain coping skills approaches have been incorporated into clinical recommendations. And these are just some examples. But basically what they say is no matter what medical treatments people are getting, they should also be learning these skills. So we're taking a multimodal approach to pain, and this helps over and above any medical treatments. So a recommended approach, often underused in clinical care because pain physicians don't have time, because it may not be offered nearby, or they don't know how to refer to it. So a variety of barriers have led to it not being used as much as it could be. And that's one of the barriers that we wanted to overcome by using a digital health approach. So traditional pain coping skills training has often been delivered in scheduled training sessions. They used to be primarily in person. Now telehealth is often the format. It ranges, but about 8 to 12 weekly sessions of about 60 to 90 minutes each. So they're scheduled, usually small group classes. And usually delivered by a specially trained PhD level psychologist. There aren't enough of them. So in recent years, people have been testing having this approach be delivered by other healthcare specialists, social workers, nurses, for instance. So what do we like about therapist-delivered PCST? These involve supportive interactions with the therapist and with peers in a group setting. And the peers are important. People learn a lot by observing other people's questions and responses and experiences. So when we were thinking about a digital health way to deliver this intervention, that was really important to us. It's easy to personalize training with a therapist working with you one-on-one or in a group. And there's a strong potential to develop that therapeutic relationship that's important to these kinds of therapies. On the other hand, it requires a substantial time commitment of a trained therapist. I mentioned there aren't enough of them, and of the other costs or resources, so space or scheduling, and those kinds of things. It's not accessible in all geographies. So for instance, in rural areas, they may not have access, or in underserved communities. And not everybody is able or willing to attend scheduled therapist-led group therapy. So this is what we had in mind when we started this project 15 years ago, to increase access to pain coping skills training using an online training platform. And we decided to make it self-completed. So our approach does not require a therapist or a therapist surrogate or a human being of any kind. Now, at the time, the common wisdom was that you really had to have a human being involved for digital health interventions to be engaging and to have high adherence. We decided that we really were going to go for a very easy to disseminate, scalable approach by eliminating the therapist altogether. And I'll tell you, it was really a fun and eye-opening experience for me. I'll tell you how we went ahead and did that. But again, there are some pros and cons to this approach. So here, we do think that the digital health platform increases access. People can access it at home. They just need access to the internet. Low cost scalability, especially if self-completed, as I mentioned. People can do the training in a standardized way any time of day or night, and they can review it anytime they want, or as many times as they want. I tend to think it's more easily integrated into medical care, and we do have clinicians referring people to use painTRAINER. They just say, go to this website, give it a try, see what you think. It's that easy. And also, we know from evidence that online interventions can have effects similar to in-person therapies. We're seeing that over and over again. Some of the cons that we've run into over the years is that there's a rapidly changing technology environment. At one point in time, the first version of painTRAINER, which was then called painCoach, just stopped working because the hosting environment changed and we had to rebuild it, which is not inexpensive. We didn't have those benefits of the live therapist interactions, so we had to figure out how to mimic them. And adherence can be very problematic in online interventions. We typically see adherence rates between 50% and 75%. So this isn't for everybody. A little bit more hand-holding pushes that adherence rate up, but it's not 100%. But then again, not everybody shows up for in-person training or telehealth training either. This approach may not appeal to everyone. There's a tendency to think that older adults may not want to use an online approach. I think that more and more we're seeing they actually will and do, and we don't count them out at all. But there is that knee-jerk reaction and this fear that people won't like to use it. And sometimes I've noticed that keeps clinicians from offering it to some people. And of course, we know that access to internet can be difficult to come by in some communities. So these are the cons. Some of them we can overcome more than others. Some of them time will take care of, but it's just a part of the digital health landscape. So as we launched into it, our challenge was to take those therapeutic active ingredients that come from therapist-led PCST and translate them for a digital environment. And we wanted to keep in mind that if we failed to do that, then we've just got an online education website that people may or may not benefit from. But we really wanted to engage people in the ways that PCST is meant to engage people. And I mentioned the collaboration, the individualization, not having a therapist online, keeps that from occurring. We also wanted to capture that vicarious learning through other group members. I am a social health psychologist. This was really important to me. So we started with focus groups. Now, we did start with a physician focus group. And one of the things I learned very early on was that they find chronic pain patients very frustrating and difficult to treat. That pain patients also often come in expecting to be cured or hoping to be cured. and being disappointed, maybe not sufficiently well prepared for the idea of managing chronic pain instead of eliminating it. And, other things they told me were things like, it's rewarding when you treat a patient to see that patient get better. It's hard when your patient isn't getting better or won't get better to any substantial degree. So that can be a hard thing for physicians to manage in their daily practice. Also, they don't quite, know what to do with these patients a lot of times. So they tend to be very welcoming of this approach, which has been helpful for us. We moved on to patients because we decided to go straight to patients. We had started thinking that we would do an intervention that engaged both physicians and patients, and then decided that we weren't going to try to work our way into the clinical workflow in a direct way, that we would really engage patients instead. So we did this work in North Carolina in an area that covered both rural residents and more suburban, not really urban, well, maybe in Durham. And so we had a lot of people who were older adults, a lot of osteoarthritis patients, some of whom had never used a computer before. Nonetheless, there was an enthusiasm for learning these skills and for doing it online, a lot of willingness to try it, some concern about whether they would feel isolated or stay motivated doing it at home. They said that 15 to 30-minute sessions would be ideal. Sometimes people who have osteoarthritis in the hips or knees or in their hands find it difficult to sit for long periods or work on a computer for long periods. So we had to keep that in mind. We couldn't do our sessions in 15 to 30 minutes, so we've built in a break and specifically point out this is a good time to take a break. Which is another thing they mentioned. We proposed to them that we would have a digital health coach who would talk to them and lead them through the training. And they really liked that idea. They wanted this to be an average person, not glamorous or robot-like. And now that may change today. It's very different. We're used to avatars and such today. At the time, that's not what we had in mind, and we couldn't have done that at the time. They wanted feedback on their progress. They wanted motivational messages and information about other people's experiences. So here's our approach to developing this digital health intervention. It looks a lot like other approaches. So we started with our focus groups. We designed one session. We got a lot of user feedback. We made changes to it, went on to other sessions. Iterative development approach, lots of user feedback. What's different about our approach is that for every single session, we started with the therapist-led protocol. I developed a proposal for how we would translate it to the digital health platform. I sat down with my 4 clinical psychologist colleagues who collectively had over 90 years experience delivering pain coping skills training. They looked at my proposal and they all said, that is not going to work. That's not how we do things. Let me tell you what we say here. Let me tell you what the problems are. Let me tell you how we explain this skill to people or how we overcome these problems. And we worked through every single session that way. That took a good portion of a year, but it was a really fun and a kind of exciting time for me because I learned so much, and I really gained an appreciation for the importance of how this therapy is delivered and the challenge of translating that to algorithms that are used for tailoring responses and response libraries that respond in various ways to people's progress and responses to exercises in the program. We did a usability testing, and then we tested it in a randomized controlled trial that I will tell you about. But again, I want to go back to this idea that I think having clinical experts on the team for a project like this is really critical. They know where people are going to have problems, what kinds of problems they're going to have, how to overcome them, and really the best, most time-tested solutions for making sure people benefit from this approach. And that's what we were able to build into painTRAINER. So what we ended up with is an 8-session program. And we asked people to do about 1 session per week over about 8 to 10 weeks. We tell them that if they miss a session, that's okay, just like start again the next week. They're about 35 to 45 minutes each. We can pause for breaks. We do have our virtual coach, and we use her to provide not only a sense of support and accountability, but also to deliver the training. I've mentioned how we incorporate expertise of therapists. Now, because we want this to be sort of broadly applicable, we do most of the training in audio format with just minimal reading. And I think people have really liked that approach. And I've mentioned that we develop tailoring algorithms and responses that try to make people feel like the coach understands them, the program understands them, and they really benefit from it. And we have gathered some data on that. And we made it really easy to use. You go in, you do one session at a time in a set order. On each screen, you go forward, you go back, you pause, you can go home. That is pretty much it. Exercises are very, very simple, and we got a lot of usability testing done to make sure that people can do this regardless of their level of computer expertise or experience. So here's what our home screen looks like now. This is not the way it looked like early on. It's changed over time, probably time for an update. One of the downsides of digital health, things change. It's not inexpensive to update these programs. That'll be an upcoming challenge for me. But you can see there are 8 sessions here, 8 skills. The ones that they've completed are in gray, and each one has a toolbox, so people can very easily go back to certain sections of each session. I can go back and review the therapeutic rationale. I can go back and listen to the audio for a relaxation exercise, for instance. The green box shows the next session, and the blue boxes they don't have access to. They have to work up to those. We want them done in a certain order. We kind of front-loaded the training so that we put relaxation up front, because we find a lot of people like it and get a lot of benefit from it, and that's worked out well for us. We consider a therapeutic dose of painTRAINER to be getting up through the 6th session, and we found some empirical evidence for that. So if they skip the problem solving and behavior change maintenance sessions, they still get benefit, but we do like them to do that, and people do like those sessions. So I mentioned the therapeutic rationale, and it starts with this very simple idea of, what is gate control theory? How is it that you can have physical damage to your body but not experience pain? And we talk about neuromatrix theory, or the way that chronic pain can rearrange segments of the brain over time and their connections with each other to perpetuate pain, and why it is that behavioral and cognitive and emotional things can influence that gate or influence those connections. And this is why we teach them these skills. So this has been really important. And a lot of people say they like this because they're very sensitive to the idea that we might tell them that pain is all in their head. They really don't want to be told that. But when they were told that these skills can actually start to rearrange those connections between the areas of their brain, or to open the pain gate or close the pain gate, this is something that's easy to understand and I think very motivating for people. So a typical painTRAINER session starts with exploring. Now, I don't know if you're familiar with cognitive behavioral therapy. There's homework. You learn the skill, then you've got to go practice it in daily life. If you're not using it in daily life, it's not going to benefit for you. So we start usually with kind of a review of the practices that people do. They tell us how many times they practice. They tell us how it went. I'll show you a little bit about how that works. Of course, the first session starts with the therapeutic rationale. There's no past skill to review. Then they go on to training in their new skill. There's a guided practice. We always have them try the skill right then and there. Then we do an interactive exercise to explore how it went for them. What did they like about it? And we always start with that. What was good? What did they notice that was helpful for them? And then we go to, if you had any problems or if you have any concerns, here's the common ones, here's how to overcome those. Then we have them set practice goals, and we suggest how many times they should practice, and we allow them to report their practice, and we provide tips for working this into their daily life and remembering. And then they make an appointment with the virtual coach, who says, is the same time next week good for you? Come back, I'll be expecting to see you. So here's our coach. That's Kelly. Kelly is actually our voiceover artist. The actor who is supposed to be the coach didn't show up, and Kelly was right there. She has chronic pain. She agreed to be our coach, and for 15 years, she's been our coach. So she'll come on the screen and say, things like, let's take a moment to talk about how your progressive relaxation practice went. And we don't expect people to know, like, if you ask me that, I'd say, well, I laid down and I felt more relaxed. I don't know what you want me to say. So what we do is we use our characters to help to model what it is we have in mind. So this is our vicarious learning. We've got 3 characters, and they can press on the character to have the character say, well, I tried mine while I was sitting up, and I do it in the morning. And I was, I thought I was going to fall asleep for a little bit and that the noise was going to be distracting. I was really worried about that. But then I found it actually wasn't so bad. I closed my window, and they talk about things that people typically talk about. And then we have our user complete an exercise. We call this the bucket exercise. They drag these little squares that say more or less or no change to various adjectives: relaxed, happy, calm, clear-headed. Those are some of the positive ones: nervous, frustrated, stiffness, pain, fidgety, sleepy, some of the negative ones. And depending on how they respond, we count things up and do some calculations, and we have the coach respond. In this case, the coach is saying, it looks like you've noticed some positive changes. Many people feel this way. And then if they have some concerns or issues, they can explore tips for managing them. And then the coach reminds them that these are skills, and the more you practice skills, the better you get at them and the more you benefit. So that's sort of a typical training flow in painTRAINER. So once we had the full sessions, we had all the sessions completed and we'd user tested them, we did a small randomized controlled trial in people with osteoarthritis. It was a 2-arm trial, University of North Carolina. It was at the Gilling School of Public Health, Global Public Health at the time, and Duke University, where Frank Keefe and Tammy Summers, Laura Porter, and Daphne McKee, those were my 4 clinical colleagues were. We had a very diverse sample of 103 men and women, mostly women, with hip or knee OA and significant osteoarthritis, I should say, pain. And what we found is that, first of all, 91% of them completed the whole 8-week session. Now, we did a little bit of hand-holding. We introduced them to the program up front and showed them how to use it. We gave them all iPads to use during the study, showed them how to use those, and it worked out really well. We did have some people who'd never used a computer before, or who were very nervous about it. I think we had somebody who was over age 90 who did this. And most of them also completed the post-intervention assessment. So this was like a really adherent group. And what we found was that we found a reduction in pain for women, not men, of Cohen's D, so standardized mean of 0.33. That's clinically significant-ish for pain. It's you're usually looking at 0.5, but a lot of people have mentioned 0.3 as being clinically important. We didn't find an effect for men. We don't think there's a gender difference here. We've never seen this before. What happened was when we were screening the men for pain, and they said, yes, I have some pain. And we let them into the study. And once they were in the study, none of them had actual pain. So there was really no place for them to move. So I think it was just a screening failure in this particular study. For everybody, though, we did see an improvement in self-efficacy for managing pain. So that was Cohen's D of 0.43. And then we saw some smaller effects for things like pain-related impairment, pain anxiety, positive affect, and reduction in negative affect. But mainly we saw that self-efficacy and the reduction in pain severity. They also reported on how they felt about our interface. And over half of them said they strongly agreed or somewhat agreed that the coach understood them. So there's our tailoring algorithms and knowledge database. It helped them with difficulties using the skills. It convinced them pain coping skills were important. Hearing about other people's experiences was useful, and the exercises helped them understand the skills, and the information was useful. So in those specific regards, we thought we were doing a pretty good job with our interface. Now, we still had people reporting that they need more help remembering to practice or remembering to come back to the sessions. And we tend to see that more in our cancer patients than in our musculoskeletal pain patients. Don't know why, but that does happen. After that, we published those data, and our collaborator in Australia, Kim Bonnell, who's a rheumatology specialist there, a physiotherapist, decided to pair pain coach, as it was called at the time, now painTRAINER, with online education and video conference physiotherapist-led exercise, and various study arms, and we never were able to separate out the effects of painTRAINER over and above these other things. But as a package, she found very good findings for pairing painTRAINER with these other modalities. So you can imagine that learning pain's coping skills while you're doing physiotherapy may help you not only adhere to the physiotherapy, but gain more from it because you're not worried about it hurting so much. We've also had a colleague at Wake Forest, Dennis Ang, who's an MD, and he's interested in chronic pain in primary care. So he paired painTRAINER versus painTRAINER plus nurse support, thinking that that would increase engagement. He actually did not find that adding the nurse helped. Both groups experienced benefits in terms of their pain intensity, not clinically significant, and pain interference, clinically significant. So even if you can't always reduce pain severity, sometimes these skills help people do more of their daily activities despite that pain. So this is what we're seeing here, but no help in having a nurse add to the program, which is a little bit surprising, but interesting to see. After that, there was a series of articles in the New York Times talking about psychological approaches to treating chronic pain. And somebody interviewed in the article mentioned painTRAINER and one other program. And after that, we started seeing clinical teams asking us if they could refer patients to painTRAINER. As long as it's up and running for research, we've made it publicly available. So we do know that there are some clinics that are routinely referring people to it. A challenge for me will be to keep it alive after the grants end. I'll talk about that more in a bit. We've also, I mentioned that some HEAL studies were funded using painTRAINER. What happened was the first round of HEAL RFAs. So this is helping end addiction long-term. It was really geared towards finding ways to reduce opioid addiction and opioid use during chronic pain. There was a very short lead time. We had 4 or 5 PIs approach us to see if they could incorporate painTRAINER into their grants. It was easier than trying to find therapists and putting together a way to deliver pain coping skills training through therapists. We said yes, help them write the grants, and I think 4 of them got funded. They're wrapping up now. So I didn't put the name of the PIs or projects on here because these are projects that are either being analyzed or we're working on publishing the results right now. But one of the things we found is that a skills-based virtual reality chronic pain management program was not superior or inferior to painTRAINER. They were equivalent. We didn't see differences in pain interference, anxiety, or pain catastrophizing. A substantial proportion of people did experience benefits in terms of reductions, clinically significant reductions in pain severity, but they didn't differ statistically. So almost 23% for virtual reality versus 32% for painTRAINER. We did see a greater benefit for pain coping self-efficacy for painTRAINER. It's not surprising. VR and pain coping skills training are very different in that respect. And pain coping skills training really builds a lot of intervention to building self-efficacy into the intervention. The The one that's really, I think, going to put us on the map, though, is the second one. We've got to revise and resubmit in a major journal, and it's a large trial covered out at multiple sites throughout the United States, several thousand people, that compared painTRAINER to phone-delivered pain coping skills training by clinical psychologists versus usual care in both urban and rural settings. And they studied high-impact chronic pain. So again, this is the pain that not only is chronic, but interferes with daily activities, work, and various aspects of life. They were equivalent. So painTRAINER and phone pain coping skills training were equivalent. Clinically significant benefits for both, and both of them were superior to usual care. We're very excited to see this published, and I think it really gives us, a nice strong evidence base to moving towards implementation and figuring out some of the details of how we'll make this sustainable. Another study that I'm really interested to see findings from, and they should be available any day, use painTRAINER as the first step in a step care approach. So first, they started with non-invasive medical, non-medical treatment, non-invasive treatment. So painTRAINER or with duloxetine, which is a medication used for managing pain, versus duloxetine. We'll see how that looks. And then for people who didn't respond to this approach, they go on to more invasive medical procedures. This is for people with knee osteoarthritis. So you can imagine there are various kinds of things that we're trying to help people avoid, various surgeries and other medical techniques that are expensive and can cause disability. We should have those findings soon. Oh, stepping back for a moment, we started in osteoarthritis because most of the evidence for pain coping skills training was in osteoarthritis when we started this program. But my intention was always to move this to pain and cancer survivors who've been traditionally sort of understudied with respect to chronic pain. As I mentioned, they tend to be excluded from large pain trials. I was interested in understanding whether this would help people with pain-related that's pain related to their cancer, whether that's their diagnosis, so tumors that are invading organs or bones, or to their treatment, so radiation therapy or something along those lines. Now, one of the things I learned is it's actually really hard to tell if pain is cancer related. Patients seem to be very reticent to say that their pain is related to their cancer. I think it's a scary thought that might mean that the cancer is advancing in some way. So they tend to say things like, maybe this is, my arthritis acting up, or maybe it's just that I'm getting older. And so what we learned, one of the things we learned is that pain is pain. And our physicians that were involved in the study were telling us, go ahead and use this regardless of whether the pain is specifically cancer related or not. But one of the reasons that we were interested in cancer pain is that it's very prevalent. So people who've had a diagnosis and been treated for cancer tend to have high levels of chronic pain. So nearly 40% after curative treatment, over half during their anti-cancer treatment. So we're talking about surgery and chemotherapy and radiotherapy. 2/3 of people with advanced or metastatic or terminal cancer, and they can be, alive for years dealing with this pain and needing to, have a palliative care approach. Across all stages of cancer, over half of people have been reporting chronic pain. And of those, 38% report moderate to severe pain. So they're reporting pain regardless of what other treatments they're getting for it. So it's not well controlled. So we did a small pilot study with some people who have either multiple myeloma, and pain is a hallmark of this blood cancer that it affects bones, and also with metastatic prostate or breast cancer. Overall, we got very encouraging results. So for instance, People liked the 8-session program. We thought that it might be too long, but generally it was acceptable to them. They liked the approach. They liked the skills as an alternative to pain medications. In fact, one person said that there are times when they're away from their house and they don't have a pain pill on them, or they don't. There was another person who said, I want to go visit my friend and I can't take my pain medication and drive, who said, that's when I use the skills. Or to have these tools at home to use when you can find the time. So overall, they liked the experience they had with painTRAINER and using the skills, and they reported some positive changes. So all of them described reduced pain and feeling better equipped to manage their pain. That's the self-efficacy. Everybody liked, all the skills were appreciated by at least one person. So there was no indication that we needed to remove any of the skills. They used them in a very creative way. So it wasn't just that they used them for pain. They said, if I'm anxious going to the doctor, I'll do my relaxation skills then, or, they can help you fall asleep and things like that. So that was really interesting to us, because cognitive behavioral therapy is used for sleep disruption and it is used for distress. So that's a way where we can maybe repurpose the skills that people use to manage not only their pain, but other kinds of issues as well. And the really interesting thing too is that people reported that they're enjoying their social and family activities more, and that their family members were noticing a change. Let's see, one person said, my family saw me helping myself rather than them trying to figure out how to help me. And when I told them I was going through this program, they said, that's amazing, because we see a change. So there was a lot of support from family. I know another person mentioned a story where he'd been isolating himself. He didn't feel well. He didn't want to be a burden on his family. His family wanted him to join. They hadn't even really known that. They had a conversation about it because he was using the program. He started joining them more, and it turned out to be a really life-altering experience for him. So it was really gratifying to hear these kinds of stories. These skills can be really powerful. So we have now 2 ongoing studies of using painTRAINER in cancer survivors. So right now, I'm right in the middle of one called Skip Arthralgia. It's for breast cancer patients who are using aromatase inhibitor therapy. That is a therapy that reduces their estrogen. And these are for people who have tumors that are sensitive to estrogen. And it dramatically reduces recurrences and death. But it causes bone and joint and musculoskeletal pain that is so bad for so many women that it's the main reason they stop using the medications. They're supposed to use them for about 5 years, give or take a few years, sometimes up to 10 years. But this is the reason a lot of them stop using it. So we thought if we can teach them to manage their arthralgia pain with these skills, could we not only make their quality of life better, but could we possibly increase their adherence to aromatase inhibitor therapy? So those are some of the things that we're looking at in this study. We're about halfway through. We've got another year of enrollment going. We're also doing a broader study of people with any cancer diagnosis. This is led out of the Wake Forest NCORE research base. So this is a large national collaboration between medical centers and practices across the country. And this should be wrapping up in a few months. And we're comparing painTRAINER to enhanced usual care, so some educational information about chronic pain. And we'll be able to learn these findings a little bit later this year. It's another HEAL study. Just a few more minutes. So people can use painTRAINER. It's currently publicly available. There are 2 versions of it. One is the US research version. It's only research in the sense that it monitors people's usage of the various components, and then they have to register and tell us which study they're in, or they can say, I'm not in a study. It's English language. We do have a Spanish language version that was very carefully culturally and linguistically tailored. That one's not publicly available yet. We just finished a usability pilot test of that. So www.mypaintrainer.org. People can use it as long as it's up and running, which is as long as I have grant funding or figure out how to make it more sustainable. Earlier I mentioned my Australian collaborator, Kim Banal. She paired it with physiotherapy, liked it so much that she approached the Australian version of the Arthritis Foundation, who have adopted painTRAINER, and they make it freely available on their website and keep it up to date. So even if the US version comes down for some period of time, the Australian version is available always, for the foreseeable future anyway. And both of them are free. When I started this project with Frank Keefe, he asked me very specifically if I would be willing never to commercialize it. It should always be free to the users. Now that's going to be a little bit of a challenge, for sustainability. You need some funds coming in to keep something like this sustainable, but I have some ideas for business models. In any case, it's out there, and we hope to keep it out there for quite a long time. So future directions. Finding a sustainable source of funds to keep them alive and working, making the Spanish language version out. I've got a grant pending with one of my colleagues in medical social sciences, Alex Sahodios, to develop a version for young adults. You can imagine that a program created for older adults and a program created for young adults needs to look very different. And she has a community advisory board of social media influencers who we would involve in adapting this for young adults. We're also looking at ways to embed painTRAINER into the clinical flow at Northwestern Medicine. So we're looking at using AI, machine learning, and natural language processing to identify people with chronic pain and automatically refer them for use of painTRAINER. So we're seeking pilot funds right now to begin that process. And then I think I've mentioned sometimes you have to rebuild these projects, and it can be expensive. So I would actually really like to rebuild this from the ground up, make it more scalable, and also maybe not require people to use the skills in a given order, allow them to start with the skills that either they've been told by a clinician they should focus on, or that they think they would like best, see if that matters. And then also create some disease-specific modules. So there are some ways that chronic pain differs across various diseases. So we'd like to incorporate that. Right now it's generic. It's just any chronic pain, which has worked well for us, but we want to also be able to give people what they need given their own diagnosis. I should also mention that acceptance and commitment therapy, which is a form of cognitive behavioral therapy, has become increasingly used in recent years, sometimes even has effect sizes greater than cognitive behavioral therapy. It could matter, different people may benefit from one versus the other. I would like to explore adding various facets of ACT into painTRAINER. But those are some of the things that I hope to do in coming years. I don't want to leave without acknowledging that we've been supported through multiple NIH institutes. Especially now, we really appreciate that. Do not take it for granted. We've also received funding from 3 different cancer centers at UNC, at Hackensack University Medical Center, and of course here at the Lurie Comprehensive Cancer Center. And this is just a very small part of the people who've collaborated with me on this project. It's been 15 years, a very large group, very good team, and I just want to acknowledge them as well. And that's all I've got. Thank you again. Thank you for the invitation.
Thanks to those of you who joined us in the room and online. Until next time.